So what happens in this illness we call addiction, a disease of the brain? As I'm teaching the students, they learn how to evaluate an individual. Actually, they're examining the brain function of the person who comes into our treatment program. We have to identify what the symptoms are, what the signs of the illness are. We have to put together the pieces of the puzzle and come up with the diagnosis. In the same way that when you go to your primary care physician with a cough, he asks you all kinds of questions. In his mind, a cough can mean at least 20 different diagnoses. He has to figure out which one it is. So when he's asking you questions, he's ruling some out. He says, well, it's probably not that, it's probably not that. So for example, he's saying, have you had a fever? Do you cough up any mucus? What color is the mucus? Do you cough up any blood? How long have you been coughing? Do you get short of breath? Do you have chest pain? On and on and on until he's narrowed it all down and he's, oh, this is your diagnosis. We do the same thing in psychiatry, asking lots and lots of questions, trying to understand. We're actually examining different circuits within the brain because each illness consists of a number of circuits not working well. So we're ruling out illnesses. And by the way, we'll get to this a little later, there are many medical problems that occur somewhere else in the body that can affect the brain and create these syndromes. So for example, if your thyroid gland is not working very well, it's not producing enough thyroid hormone, hypothyroidism, that can look exactly like a major depressive disorder. In some unfortunate people, they may develop a tumor in their pancreas. And the only presentation is a major depressive disorder. They have no pain, no other symptoms. And they turn out to have a tumor in the pancreas, which is causing the effects on the brain to create the symptoms of major depression. It gets pretty complex. I need to teach you that addiction is a brain disease. If at the end of this lecture you don't believe it's a disease, I want you to raise your hand and I will keep going until I do. It's extremely important. We used to think it was a social problem. The person chose to drink too much or use too much cocaine or to use substances despite negative consequences. Just because bad things keep happening, he keeps choosing to use the substance. Just stop, right? Nancy Reagan had it. Just say no. Well, were we naive back then in the 80s? We had no idea that addiction is actually a brain disease. It's not a social problem. When I was in medical school, they taught us when we're writing up an initial evaluation, right? We're asking you about your present illnesses, your present symptoms, your past medical illness, your allergies, your surgeries, your social history. Now, social history is very important, right? If you develop some type of breathing problem, it's very important that we know that you worked with asbestosis, right? Many aspects of your social history can contribute to a vulnerability to developing all kinds of medical problems or psychiatric problems. So when we're writing this all up in an organized way, we were told to include any use of alcohol or cigarettes or drugs in the social history because it was a social issue, right? Today, we teach the students, no, 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 it doesn't belong in the social history. It's a medical issue. It belongs in the medical history. You know? I remember when I was doing medicine at New York Hospital, I was on call on a Sunday one day. I was the only intern, again, once all by myself. I had 40 patients again. And after doing my rounds and drawing bloods and taking care of everybody's complaints, I found myself walking up and down the hall thinking, this person is here because of cigarettes. This person is here because of alcohol. This person is here because of cigarettes. Every single one of them was accounted for. Cigarettes or alcohol. On a medical floor. They were all there for medical problems, all caused by one of those substances. So, to use as a choice, I see. I should have warned you. Some of this is rated R, some of it's rated X. Crocodile, street name for desmomorphine, a type of opiate, was becoming increasingly popular in Russia. We all anticipated that it was going to make its way here. Thank God it has not yet. But this person didn't start out like this. She injected. She got high. She liked the feeling. She injected again. The tissue started to die at the injection site. So she found a different place to inject, and so on and so on and so on. Did she choose to do this? Well, to make a choice is a brain function. There are different circuits involved. You're going to learn a lot of anatomy. You're going to hear me telling you what these circuits are, these different areas of the brain. I want you to try to remember some of them. You'll hear them throughout the weekend. We know, for example, that right in the center, down fairly deep, is called the anterior cingulate cortex. It's involved in the process of making a choice. Well, in functional MRIs, which show activity of the brain, in that person who is told to make a choice about something, you don't see the anterior cingulate cortex lighting up the way it's supposed to. Is that person's fault, that the anterior cingulate cortex is not lighting up? Neurologic, right? No more than you expect the person who has a lesion in the motor cortex and a right paralyzed arm to raise his arm when you tell him to. You immediately recognize he doesn't have the capacity to raise his arm. He's got a lesion in his left motor cortex. By the way, this part of the brain is responsible for this side of the body and vice versa. By the same token, if you woke up and your arm was paralyzed and you went to the neurologist, he doesn't have to do a CAT scan or an MRI. He can just examine you, see that your arm is paralyzed, and point to where the stroke is. Because he knows what part of the brain is responsible for that. Before and after. Did he choose to look like this? To do that to himself? Dr. Volkov, the director of
Brain
National
science has
Institute
told
on
us
Drug
an
Abuse.
enormous amount. To start with, we now understand why certain drugs and not others, for example, can produce addiction. And that relates to their ability to directly or indirectly activate reward centers that are modulated, among others, by dopamine. But we've also started to understand what are the changes in the brain associated with repeated drug use that ultimately lead to the loss of self-control and the compulsive intake that characterizes addiction. And what's interesting is in the process of understanding what are the circuits involved with the loss of control in addiction, we've also started to understand what is the neurobiology underlying not just self-control, but in the process, the concept of free will. The ability to want to do something and be able to carry it through, or the ability to stop something and be able to inhibit. NIDA's neuroscience priorities are very ambitious. Number one, to develop the science that will allow us to better understand the mechanisms that lead to vulnerability for drug experimentation and ultimately for the transition from experimentation to addiction, such that we can develop better prevention strategies. The other one relates also to the knowledge that will allow us to understand what are the genetic, epigenetic, molecular, circuitry, and social level constructs that drives the transition from drug intake that is controlled to drug intake that is automatic and compulsive in addiction, such that we can develop better treatments. And that entails both behavioral interventions that can help remediate some of the changes produced by drugs, but also medications that will also help us accelerate the recovery of the brain so that it can go back to its state where it can regulate and control that desire to take drugs.
I'll explain a lot of what she has touched upon. I know her, you got to get used to her accent, but she has a lot of important things to say. I read every word she writes. She's one of the pioneers in helping to establish that addiction is a true disease of the brain. It's defined as a chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. Let me break that up. Chronic meaning once you develop it, you have it for the rest of your life. That doesn't mean it remains symptomatic, right? Some people with, in fact, most people with hypertension, I have hypertension, I'm asymptomatic, but it's a chronic illness, so I have to keep it treated for the rest of my life. Relapsing. Most chronic illnesses have relapses associated with them. Sometimes my blood pressure unexpectedly is elevated. I have to have it addressed. The medicine has to be adjusted. I need a medical intervention. Sometimes people with diabetes, with their glucose under perfect control, will suddenly develop a ketoacidosis. They have to go into the hospital and get stabilized again. It's a relapse. And I could go on and on with other medical illnesses. Addiction is no different. Compulsive drug seeking. The person is driven to seek out the drugs. And I'm going to teach you about the parts of the brain that are responsible for that, despite harmful consequences. Even that individual who was developing the necrotic limb continued to inject, despite negative consequences. You got to wonder, what kind of brain does that person have? What has changed about that person's brain that she can't recognize how she's harming herself and just stop so that all of that harm can be undone, right? For you, it's obvious. You're saying, why would she do that? Her brain is not producing that question. She knows why she's doing it. She wants the drug. An elaboration of this definition. A primary chronic disease of brain reward, motivation, memory, and related circuitry. Let me stop there for a second. Primary, meaning that something else doesn't cause the addiction. You see, you're going to learn about the genetic vulnerability to that person who, when exposed to a substance, then experiences changes in the brain that eventually lead to this changed state that we call addiction, as opposed to the person who doesn't have that vulnerability. You know, I once, well, a number of times, had awful pain from kidney stones. Have anyone ever experienced that? You know how bad that is. I held out and held out and held out until I couldn't hold out anymore. My spouse said, you got to take this Tylenol number 3. Codeine, 30 milligrams, 15 milligrams actually. I said, all right, I'll take it. I can't take this pain. I took it and promptly threw it up. I said, I'll take the pain. Couldn't stand it. Didn't like how it made me feel. It was awful. It showed me I don't have that vulnerability. Being exposed to that opiate didn't lead to changes in my brain that eventually led me to develop this compulsive need to seek out the opiate and continue to use despite negative consequences. The vulnerability. Disease of brain reward, motivation, memory, and related circuitry. So, where do the changes occur in the brain? Not everywhere. There are no changes that occur in the visual cortex or the temporal cortex or the somatosensory cortex, but you see changes in the prefrontal cortex. Let me start teaching you about the different parts of the brain. The very front of the brain is called the prefrontal cortex. It is the most highly evolved part of the brain, much more evolved than any of our simian cousins. It's responsible for judgment. Judgment is the capacity to predict the likely consequences of one's choice. If I do this, then this is likely to happen. Right? You're standing on the curb, about to cross the street. The Mack truck is barreling down, and you say, if I try to cross the street now, then I'm likely to get hit. That's exercising judgment. You choose not to as a result of that. Very simple example of a complicated brain function. Other functions in the prefrontal cortex called executive function. It's planning, organizing, putting a sequence of steps or tasks into place in order to accomplish a certain goal. Something called working memory. That's the memory that is it's used when you're engaging in daily simple tasks. I'll give you an example. I want you to all picture yourself going to the grocery store to buy a gallon of milk. You're standing at the cashier and you hand a $5 bill to the cashier. The gallon of milk costs $3.69, and now you've calculated how much change to expect so you don't get gypped. Right? I'm stimulating a very specific part of your prefrontal cortex right now. It's called the dorsolateral prefrontal cortex, and that's responsible for working memory. I've just stimulated it in every single person. If we had you all in a functional MRI, we'd see it light up. You've engaged your working memory to imagine something, kind of manipulate the picture, right? You're doing a calculation in that memory. And then we drop it and you let that just float away. You're not storing it in your memory for any length of time. It's useless information. Right? A very highly evolved part of our prefrontal cortex that is also affected by this disease called addiction. Right above the eyes, down deep, as the brain folds under in the front. It's called the orbital frontal cortex, involved in putting the brakes on activity. A much deeper part of the brain, in the midbrain, we develop these desires, cravings, wants. They become conscious, right? We're now aware of them, and we have to make a decision. Do I act on this now? Do I run out and get a banana split because I'm craving it right now? Leaving you all aghast at my behavior? Or do I say, no, I'm going to put that in my memory and I'm going to act on it later at a more appropriate time? Right? The orbital frontal cortex is involved in that process. It ain't working too well in addiction. Thus, you see the need for immediate gratification. I develop a desire, a craving, I'm acting on it right away in addiction. Other structures, the limbic system. The amygdala is responsible for producing anxiety and emotional memory, fear. When you walk around the corner and you see the lion staring at you, your amygdala goes wild. It starts a chain of events. You've remembered biology again, 9th grade, and you thought you would never need that, right? The fight or flight response. Do you fight the lion or do you run like hell? The amygdala is helping you to start that process of thinking in order to know how to act. Right next to the amygdala on each side is the hippocampus. We'll keep coming back to these structures, by the way, so I'll drill them into your hippocampus. The hippocampus is responsible for short-term memory. Among other things, it helps with mood regulation as well. We know that in that person who experiences a major depressive episode, for example, that the hippocampus on each side of the brain has shrunk. It's involved in mood regulation. You put that person on an antidepressant, and after a couple of weeks, she says, I feel better. You rescan the brain, and the hippocampus has grown again, back to a normal size. There's something very important that occurs, many things, but welcome. One of the most important functions of the hippocampus, it's the seat of neurogenesis, the birth of neurons. Back when I was in medical school, they taught us you don't grow new neurons in adulthood. You do that in infancy, and by the time you get to the adult brain, the only thing that happens is neurons die over the decades before you die. Now we know that's not true, that neurons are born every single day in every one of us in our hippocampus. And now we also know that in diseases like major depressive disorder and post-traumatic stress disorder, what's happening is that those neurons are not growing. They're not being born. There's no neurogenesis. The process has been arrested And that's why you see the shrinkage on the MRIs. Our treatments reverse that process. I'm illustrating all of this to you so that you're learning about the very specific structures in the brain that are responsible for very specific functions. And these are the structures that are changed in that individual with the vulnerability to developing addiction when that person becomes exposed to the substances. Those substances, over a long-term basis, the length of time of which is different for different people. It could be a very short period of time for some people. It could be years for other people. For those changes to come about, and for you to then see that changed brain. Substance use disorder, severe, is interchangeable with addiction. In that DSM-5 that I referred to earlier, the book of disorders, the group of researchers in this area chose to use this term, substance use disorder, instead of the word addiction. But you'll hear both, so I want you to know that. We've talked about all these criteria. So, what's the difference between addiction and dependence? As doctors, a very common question for us to hear from the patient is, will I become addicted to this medicine? Right? Now we kind of chuckle because we know the difference. I just mentioned those structures in the brain that are involved in addiction. Well, the areas of the brain that are responsible for dependence, particularly physiological dependence, are completely different. They're way down here. So if you take, for example, even a benzodiazepine, Ativan, Xanax, Klonopin, Valium, for a very specific medical reason, and you take it for a number of weeks, it changes, provided that you don't have the vulnerability to addiction, right? This is the person without addiction. It changes these areas of the brain down here, such that you can't stop the medicine abruptly without experiencing a withdrawal syndrome, because the brain doesn't like abrupt change. It can tolerate gradual change, but not abrupt change. You stop taking that medicine, those areas of the brain start to go wild, too active. Can't tolerate the change. So it creates the withdrawal syndrome. That doesn't mean you suffer from addiction. Completely different process. So why do people take drugs? To feel good, to feel better, to do better, curiosity, and because others are doing it. What's the problem? Well, in those people who are vulnerable, over time, they find that in order to get the same effect, they have to take more and more and more, constantly chasing that high. Right? If they stop it abruptly for some reason, they experience terrible withdrawal. Now, they know how to get rid of the withdrawal very rapidly. Just use the drug again. So you see how it begins this vicious circle. Loss of pleasure. I'm going to show you the biology that explains why over time that person using drugs to get high not only doesn't get high anymore, but prevents the withdrawal, but loses pleasure altogether. Dysphoria is a type of emptiness, sadness, lousy feeling. Inability to consistently abstain, so the person sometimes tries to quit and can't. Impaired behavioral control. I told you about the orbitofrontal cortex that's not working. It's not putting the brakes on those cravings, on the action that leads to finding the drug. The development of craving. We're going to get into that in a bit. Diminished insight, lack of awareness. I think you have a drug problem. No, I don't. Well, we're learning more about this thing called insight, awareness. What part of the brain is involved in that? Well, it turns out there are probably a few different circuits that interact together to create this experience we call insight. Insight is awareness. I am aware that I have a problem. We see this impaired in many psychiatric illnesses. We see it in addiction, we see it in schizophrenia, we see it in bipolar I disorder, sometimes we see it in major depressive disorder. The people around us can see that we have a problem, but the patient can't. In future lectures, I'll teach you more about what structures of the brain are involved in insight. And dysfunctional emotional response. Experiencing something around us, in the environment or in our relationship with someone, and not having a healthy emotional response, because that whole system, that limbic system, right, the hippocampus, the amygdala, some other structures I'll teach you about, are not regulating those emotions properly. I think we saw that this morning with Catherine. At one point, Rachel said something innocuous. It was simply asking a question, trying to understand something that Catherine had said. And Catherine responded in this irritated way. And it was a beautiful example of what we're talking about. She had no control over it. Now, we address it as if we expect her to have control over it, because that's how we're teaching a patient to get healthier and to actually exercise these parts of the brain. In other words, to regulate the emotion, for her to recognize, oh, she's feeling irritable, but the irritability isn't really the appropriate response to this innocuous question that's just attempting to understand. You see, you all do that automatically. It's a complex process, though, that's impaired by many psychiatric syndromes. All right, PET scans. They show activity in the brain. You're all familiar with an X-ray. Some of you have had CAT scans. A CAT scan is like a fancier X-ray. It shows more detail throughout the body, but it's still just a picture. PET scans, on the other hand, show activity. So we use PET scans to look at different parts of the brain and the activity that's occurring in those parts of the brain, very similar to functional MRIs. An MRI takes just a picture, but the functional MRI actually shows activity. So, the MRI versus the functional MRI. You see on the left-hand side, Homer's little pea brain. On the right-hand side, you see more activity. So, I want to orient you. I can't put my head back too far. So, if I were to have my head back like this, see, the front of the brain is at the top in these pictures. Now, you see the red means highly active. So the red in the looking functional MRI is active in the occipital lobe. Remember, I told you the occipital lobe is responsible for vision. So when that person is lying in that functional MRI and you tell him to focus on this picture, right, the activity in his occipital cortex is increased. That's the idea. This person is listening, so you see the activity in the temporal cortex on either side of the brain. Thinking, responsible. Prefrontal cortex. Remembering, down deep you see the red showing the activity. That's the hippocampus on either side. And finally, working, completing a task, using multiple areas of the prefrontal cortex. All right, so functional MRIs are used to identify those parts of the brain that are not working in various illnesses. You see the normal subject on the left, and this person suffering from cocaine addiction. You immediately recognize the marked decrease in activity in the prefrontal cortex. The part that's responsible for judgment, thinking through what's likely to happen. If I choose this, then this is likely to happen. This person will easily use cocaine at 10 o'clock in the morning when she knows she has to see her probation officer at 2 o'clock in the afternoon. But she can't predict the likely consequences of that choice. Well, how could she? Her brain's not working. At the bottom, here on the left, you see the healthy heart, right? The heart is a muscle, and this is showing the activity of the muscle contracting. You see the diseased heart. You can readily recognize that part of the heart that is not contracting, right? That person's had a heart attack. By the same token, on the left upper, you see the healthy brain, the yellow showing normal activity, the prefrontal cortex, and that person who's been using cocaine. You see splotchy areas in the prefrontal cortex that are not working. All right, we just covered that one. This is looking specifically at deeper parts of the brain. So you recognize the normal activity in this individual. The person with Alzheimer's, you see less activity, splotchy areas, no activity. So the brain is beginning to deteriorate. It's not fully turned on. And finally, the person who's been using methamphetamine, even worse than the person with Alzheimer's. That brain is not working. All right, who develops addiction? There are multiple risk factors, right? I talked about certain genes that create a vulnerability. By the way, just because you're born with a gene, in many instances, it doesn't mean that you are absolutely destined to developing the illness. It means you have a vulnerability. Many illnesses come about as a result of the genes interacting with the environment. So there are a number of genes identified now that create a risk for someone to go on to develop addiction. But if that person never becomes exposed to the substance, he or she will never develop addiction. So it's a beautiful example of that gene-environment interaction that brings about the disease. What factors in the environment contribute to risk? Chaotic early home, abuse, either sexual abuse or physical abuse, or neglect. You'll see in a moment the effect of neglect itself on the brain. Parents' use and attitudes toward substance use, peer influences, community attitudes, poor school achievement. These factors are often combined and lead to the worse vulnerability to developing addiction. Now, does everyone who uses heroin become addicted? No. You could have predicted that by what I've taught you so far. Right? If you didn't have the genes, or you didn't have the early environment that makes you vulnerable, and you use heroin, then you probably have a pretty good chance of not developing addiction. The converse of that is about 20% of people who use heroin on a regular basis go on to develop addiction. Most people don't. They have more of the opposite of vulnerability. We call that resilience. We'll keep coming back to resilience. Only 17% of people who use cocaine on a regular basis go on to develop addiction. Alcohol, 15%. Cannabis, 9%. I do not like telling our adolescent patients that fact. Go ahead, continue to smoke. Only 9% of you is going to develop addiction. What I do say to them is that by virtue of being in our program, they've already been defined as being part of the 9%. Because it means that they have experienced lots of negative consequences and they continue to use. So their brain has begun to change. We know they're in that unfortunate group. Okay, we'll skip that. Skip that. Remember the neglect? 3-year-old children. Normal one on the left. This is the person who has undergone extreme neglect. The cortex has markedly shrunken. Much, much smaller brain. Neglect, no abuse. Powerful, powerful effect. And it also, by the way, a nice example of how a psychological effect, right, being neglected by our loved ones, has led to a physical change in the brain. We talked about this. All right. A little further down deep. You remember I asked you which structure of the brain was responsible for experiencing pleasure. It's this little tiny area deep in the center of the brain called the nucleus accumbens. The nucleus accumbens It's connected to a structure that's a little further back, and I have to teach you these terms. Sorry to make it complex. They don't yet have street terms for these names of the brain. The other area that is connected to that nucleus accumbens is called the ventral tegmentum. There are neurons sitting in that ventral tegmentum that produce this chemical called dopamine. Dopamine is a neurotransmitter. That means it transmits information from one neuron to the next. So those neurons sitting in the ventral tegmentum, they're producing dopamine, and they send out extensions of the cell called axons to the nucleus accumbens. And when those neurons in that ventral tegmentum become exposed to things that give us pleasure. Now, the healthy things that give us pleasure: food, water, sex, and relationships. Those are the basics. Everything else derives from that. When we become exposed to those things, those neurons in that ventral tegmentum secrete dopamine in the nucleus accumbens. And as soon as that happens, we feel pleasure. Well, all substances of abuse, drugs and alcohol, do that very effectively. They produce a release of dopamine in that nucleus accumbens. Brain communication. One neuron submitting dopamine that is then picked up by a receptor from the second neuron. A message has been sent. You experience an example of a message as pleasure. Just to give an example of the complexity of these neuronal circuits. The neurotransmitter being sent from one neuron to the next. So a few more fancy names. You see the cell body of the nucleus, of the cell rather, the nucleus in the cell body. The projection is called the axon. Every neuron has one axon. Now, I have to tell you that the dendrites receive information into that neuron. Picture a tree with the trunk of the tree being the cell body and all of the branches being the dendrites. So the dendrites are collecting information, like antennas, for example. Antennae, collecting information. Each neuron has approximately 10,000 dendrites. Mind-boggling. 10,000 dendrites on one cell. And by the way, there are 100 billion neurons in each brain. Each one of us in the room has 100 billion neurons, each neuron 10,000 dendrites. That's 100 billion times 10,000 dendrites in the brain, all for communication. Now we know, by the way, that in addiction, that number, 10,000 dendrites, is markedly decreased. Maybe 2,000, 3,000. So you can see how communication is impaired from one neuron to the next. Those dendrites have decreased. The communication is impaired. Now, communication determines function. If those dendrites happen to be in the prefrontal cortex, what's going to happen to judgment? That ability to choose. What's going to happen to executive function, mood regulation, anxiety tolerance, the capacity to learn, how to be motivated by healthy things? All sound familiar? You've seen impairment in each of these areas in your loved ones with addiction. They have fewer dendrites. So all of the drugs, not just these, all of the drugs and alcohol are much more powerful in that person going on to develop addiction in having the dopamine released in the nucleus accumbens. I told you sex. So, another depiction of that. Here's one neuron on the left showing normal dopamine release and picked up by the next neuron. Now what happens in addiction? A lot more dopamine, a much more powerful effect. While I'm on this slide, I just want to share something with you. There is a theory working now and an increasing amount of research that's looking at the fact that those people who are prone to developing addiction have abnormal receptors here. This is a receptor. This is what picks up the dopamine and then turns the neuron on. In fact, it's been shown that in those people with addiction, there are fewer receptors. The ones that are there aren't even working in the same healthy way. But the fact is there are fewer of them. So one of the theories is that that individual who is seeking out the substance is simply attempting to normalize this nucleus accumbens function. Because if you don't have enough receptors, it's going to feel like this neuron isn't getting enough dopamine. The person has taught himself or herself how to produce a lot more dopamine, use a substance. I don't think I'm going to get that complicated. Let's skip a couple things. Too much. I covered that. This is just talking a little bit about genetics and its role in determining the vulnerability to developing addiction. We covered that. So we talked about the increased number of D2 receptors. I don't want to make it too complicated. We're covering a lot of the major concepts, and I don't want to keep you until 10 o'clock tonight, unless you want to stay. Okay. All right. Let me orient you. That's the back of the brain. This is the front of the brain. This is to show that in the normal state, we develop cravings, urges, desires, and the messages are sent to our prefrontal cortex. Remember, this is responsible for thinking. So you want to do something. You think about whether you should act on that now, act on it later. If I act on it, what are the likely consequences going to be, right? That is all automatic for you, and you do it in a way that then determines action or inaction. In addiction, what happens is chronic exposure to the substances is now strengthening a new pathway. This pathway goes to the motor system, eventually working up toward the motor cortex. So you see, the person is now developing the craving, wishes, desires, and instead of thinking about it, acts on it. This becomes the preferential pathway. We see that in our patients. When a patient relapses, comes back to treatment, we say, what were you thinking? And the response is, I wasn't. And now we understand what's going on in his brain to explain that. He's being honest. He wasn't thinking. He developed the desire, and before he knew it, he was acting on it. The brain has changed. We talk about moving from impulsivity to compulsivity. This is now driving the patient to seek out and use substances. What happens after chronic release of dopamine in that nucleus accumbens? Well, the brain kind of conks out, and now there's an overall decrease in available dopamine. So the person begins to experience a reduced ability to experience pleasure, more depression, decreased motivation, which then repeats the cycle because he or she has taught himself, how do I get more dopamine released in the nucleus accumbens to provide pleasure? Well, the substance. And round we go. We talk about the brain being hijacked. So there are times where we have an individual in community. Oh, you know something? It just happened the other day. We had a patient fly down from New York to come into our program. He had been using benzodiazepines and opiates, 30 years old, had his own heating and air conditioning system, was doing pretty well, was starting to lose everything. In fact, had to move in with his parents for a bit. They convinced him, after trying for a month or so, to get him into treatment. He was about to come, he changed his mind. He was with his girlfriend. He hadn't taken benzodiazepines for a couple of days. He was continuing with the opiates, but he went into severe withdrawal, and that's a seizure. Benzo withdrawal can kill. Alcohol withdrawal can kill. He had a seizure, but he was standing on the edge of a pool. He fell into the pool while he was seizing. He was about to drown. His girlfriend saved his life. Finally, the girlfriend and the family was able to use that to convince him to come to treatment. Came on Sunday morning. By Sunday night, he wanted to leave. We told him he had to submit his 24-hour notice. He had signed an agreement to that effect on admission, which is what we do for everybody, to give us some time to talk him out of it. Next morning in community, we're all beating our heads against the wall, trying to convince him to stay. You almost died. And on and on and on, spending hours. There was no getting through to this guy. I know, but I'm leaving. I know, yes, I'm probably going to die, but I'm leaving. He left. So there are those times where we have to remember that he's not the person talking back to us. He's not the person saying, I'm leaving. It's like this.
Dr. Klein.
Yes, I'm Dr. Klein. This is Dr. Tandy.
Sharon, things have gotten worse since I phoned you. I think you better go upstairs.
Is she having spasms again?
Yeah, but they've gotten violent.
Did you give her the medication I gave you?
Yes.
What was that? Tansy. Well, that was Ritalin.
Chris, doctors.
Mother,
Miss McNeil, Dr. Tandy.
What is it? What's happening? Stop! It's burning! It's burning! Do something, doctor. Please help her. Please, Mother! We'll make it stop! He's trying to kill me! Mother! Make it...
All right, let's see what to do. Keep away!
This hour is mine.
Fuck me!
Fuck me!
Fuck me! Stay away from me!
Hold her steady. Hold her tight.
Now, is that child making those choices to behave that way? You recognize that very easily. Here, it was the devil inside, had hijacked that brain and drove the behavior. You're not going to get anywhere talking to that devil. Not even going to get to the healthy child. Addiction is the same way. We could not identify any part of that healthy brain in that guy on Monday morning. The addiction had complete control over it and was driving him to leave. So on admission, as well as periodically in a random, surprising way, we administer the urine drug screens to all of our patients. This one tests for only 12 of the most common substances. But that in itself isn't even very helpful. For example, you'll see that it picks up opiates, but it doesn't pick up all opiates. It'll pick up morphine. This particular cup will pick up oxycodone, but there are many, many opiates. So someone could be using opiates, and this could be negative. We would call that a false negative. And so we have to send that same sample to a laboratory that has more sophisticated testing than just this. This is called an antibody test. There's a protein called an antibody that is embedded in the side of the cup, so that if it gets exposed to a particular molecule in the urine, they become attached and create a reaction that shows up on the side of the cup. So the reaction shows you that that molecule has to be in the urine. However, those antibodies are not very specific. So one type of antibody that is supposed to pick up morphine, for example, may also interact with other molecules in that urine, many of which may be prescribed medicines that are not controlled substances. Antidepressants, for example, often cause false positives. So even when we do have a positive, we don't know it's real necessarily. So we have to send it out to be analyzed in something that is much more sensitive and much more specific. And that is the gas or liquid chromatography, mass spectrometry. They're chemical reactions done in analyzers that identify very specifically whether the molecule is there. There are no false negatives, no false positives, despite what many of our patients try to make us believe. This is just an example of a list of substances that this particular lab could test for. Many different opioids, benzodiazepines, stimulants. I know I'm sorry about the very tiny print, but couldn't fit it all on one screen. The metabolites of alcohol. Now, alcohol can only be detected in the urine after about 3 to 5 hours since the last drink. What that means is that somebody could drink a great deal last night, provide a urine specimen this morning, and it will be negative. And so for years, we had difficulty really identifying those people who were relapsing until just a couple years ago, when 2 particular molecules were identified: ethyl glucuronide and ethyl sulfate. It turns out that when we drink alcohol, these molecules are created in the liver. The alcohol is attached to either the glucuronide or the sulfate. And that particular molecule can be found in the urine up to 5 days since the last drink. And so if we're suspecting that someone has been drinking and that urine drug screen, the instant is negative, then we can just detect it with the ethyl glucuronide or ethyl sulfate. Additional substances, methamphetamine, cocaine and its metabolite, the marijuana metabolite, metragenine or kratom. Let me tell you about that. Metragenine is a molecule that has been found in the leaf of a tree that grows in Southeast Asia. It has properties that are similar to opiates and stimulants. In fact, in some people, when they take it, they get the same effect that they get when they take heroin. We've had a couple people come in with pure kratom dependence who went into acute withdrawal that looked exactly like heroin withdrawal, and we treated it the same way. Very powerful substance. Absolutely legal in the United States. In fact, it's been estimated that as many as 30 million Americans are dependent upon kratom, and they have no idea. It turns out the kava bars, they're plentiful throughout the country, actually provide kratom, often adding it to their drinks. And so the unaware person just recognizes that desire on a daily basis to go to the kava bar to get a drink, thinking that it's just a healthy desire. I feel like having a kava drink. When actually it's because the kratom is driving them to continue to drink. The synthetic cannabinoids, all the JWH compounds. The synthetic cannabinoids are all derived from an initial attempt to take the beneficial properties of THC, which is the psychoactive ingredient to marijuana. Very popular these days throughout the news, right? And try to identify a molecule that can provide us with those beneficial properties, right? Anti-nausea, anti-pain, increasing appetite for, in those people suffering from AIDS or cancer who've lost tremendous amounts of weight, right? There are beneficial properties to that substance. But it didn't work, except it did create a euphoria. And so the underground laboratories ran with that and created all sorts of synthetic cannabinoids that would create euphoria. We have a natural cannabinoid system in our brain. In fact, we have receptors for cannabinoids throughout the brain. It turns out the cannabinoid system itself plays a huge role in regulating other functions of the brain, fine-tuning the functioning. Sort of like a red light, you know, green light, yellow light, red light. This is fine-tuning activity. And we even have natural cannabinoids in our brain called anandamides that stimulate those receptors. Now when somebody smokes marijuana and they're exposed to that tetrahydrocannabinol, THC, it stimulates those same receptors and creates in them various effects like euphoria, anti-anxiety, increased appetite. Depending on the part of the brain, those are the effects that it gives. Now, that THC molecule stimulates those receptors only to a partial extent. They're called partial agonists. It turns out the synthetic cannabinoids stimulate that same receptor to a full extent, much more powerful. And so we often see people who have been using synthetic cannabinoids to develop seizures, psychosis, death. They are completely illegal now. Used to be able to walk into any convenience store and buy them as spice. They were sold as this dried plant material that you could burn for incense, for example. The synthetic cannabinoid has been sprayed on the dried plant material so that when they smoke it, they're ingesting the synthetic cannabinoid. Another story related to that. Here, this was quite a while back when I made this slide. But at that time, yeah, that was 2013. This laboratory could only test for 4 of those synthetic cannabinoids. The most I've seen, I think, is one lab able to test, I think, 12 of them. All illegal. But at last count, there were identified over 240 of them. So it means that somebody could be smoking any one of the other 228 and the laboratory would not pick it up. On every admission, we provide neurocognitive testing, computerized, standardized. The way this evolved is that it was found, at least 25 years ago, I think, in those patients who had suffered a traumatic brain injury, TBI, that they would come in to get physical rehabilitation. Depending on what part of the brain was injured, they would suffer those particular deficits, but they were often found to have significant cognitive deficits. That is, verbal memory, visual memory, executive function, processing speed, things that we use every day to think. They had impairment in. So studies were done and showed that actually providing exercises, cognitive rehabilitation, focusing on whatever the deficit was. So for example, verbal memory exercises, would be shown over time to improve that deficit. It was also identified after that that people with schizophrenia suffered from severe cognitive deficits. So the thinking among the researchers was, well, it's been shown to be effective in the TBI population, so perhaps we can adopt the cognitive rehabilitation strategies in the schizophrenia population and help them with their cognitive deficits. And sure enough, they did. And so that has been integrated in many of the academic centers around the country. So knowing that, I would recognize on admission with our patients that they had tremendous deficits, our patients with schizophrenia, in all of these different brain functions. And so we began testing them and identifying very specifically what the deficits were. Well, we started recognizing similar deficits in our patients with addiction. That was something that wasn't written about, wasn't researched. Nobody even talked about it. But we saw it on a daily basis. And so we started testing them as well. And sure enough, their cognitive deficits are often just as bad as those patients with schizophrenia. So it all evolved in such a way that now we perform the neurocognitive testing on every single person who's admitted. We identify the deficits, and then we prescribe the very specific cognitive exercises, all computerized again, that they engage in on a daily basis, and then they're tested periodically to see if in fact those deficits are improving. These are some of the results that you see here. This is a person who was 22 years old, came in with addiction, and you see across the board very significant deficits. Verbal memory, visual memory, processing speed, executive function, complex attention. This person could not work in a grocery store sweeping the floor. He'd forget where the broom was. 5 months later, the same person. You begin to see the significant improvement across the board.